Healthcare, important? You bet it is. It's one of this nation's top 3 industries and employers. 90% of Americans visit a doctor's office or healthcare facility every year. I'm Monica Langley. Welcome to the Haslam College of Business on the campus of the University of Tennessee in Knoxville. We are a big and compelling academic and research school because people are attracted to our excellence and our hustle. Our students, faculty, and partnerships with industry allow us to move forward with success and impact. Today's Haslam podcast focuses on the all-important healthcare sector. We delve into one of its hottest, most controversial, high-growth segments, the surge of private investors buying up healthcare facilities and providers to the tune of $200 billion a year. As we examine the pros and the cons of the phenomenon, we're fortunate to have 2 leading experts who engage in both sides of these deals and business structures. They are Mike Wiechart, President and Chief Operating Officer of Teamhealth, a top firm in healthcare private equity owned by financial giant Blackstone, and Marty Brown, President and CEO of PYA, one of the country's top accounting and healthcare consulting firms. So, Mike and Marty, welcome back to campus. Let's get started. Marty and Mike, let's jump into this. Let's set the stage with a hypothetical. We know I'm not a doctor. Neither of you all are actually either, but you're experts in this area, which I'm not. Let's pretend I am a physician in a booming medical practice, and I'm thinking about selling to private equity. Would you all give me one reason that I should want to think about it and one reason I should not? Mike, I'll start with you. What's a reason I should consider selling to private equity?
Well, I think there's probably several reasons, but if I had to pass you in the hallway and give you one reason.
Yeah, let's pretend I'm actually at a cocktail party. You all are at the same cocktail party with me, and I'm like hitting you up.
I like cocktail parties.
Don't we all?
I would say, if you ask me that question, I say probably speed and certainty of getting a transaction done, and maybe the time frame you're thinking about getting it done.
Okay.
Tends to be less complicated, all things being equal.
Okay, I like that answer, and I'm considering it. But then I think, do I really want to sell? Marty, what is one reason I would not want to sell to private equity as a physician of this booming practice?
Well, an oversimplified answer would be, if you told me that you want 100% autonomy of your practice, you just need some capital, I would tell you to think long and hard about that decision.
Okay, because I kind of like running my own show. Okay, got it. Okay, so this has been a very brief way to set the stage. Now let's get into the very complicated and nuanced topic. And there are a lot of issues we need to discuss. Operational efficiencies and cost management. Is this a slam dunk for private equity, or is it something that all business deals with, or is it especially tough in healthcare?
But let's start with the beginning. Private equity is an accumulation of investment capital from limited partners and general partners. They pool it all together, and their job is to invest those dollars in healthcare enterprises, if they're in the healthcare space, with the ability to yield a return eventually. It may be more than just the exit. And so the first thing that oftentimes can be done is to look at, where are we inefficient? Where can we improve our bottom line right off the bat? And there are things such as, well, do we need somebody answering the phone? As opposed to everybody starting to get used to automated attendance. But that physician practice that's beloved in the community and has always had this person answering the phone, and there's elderly or senior citizen folks that are calling in that want to talk to that person, that feels like change. Mm-hmm. It may be a good business decision, but it's a change and an impact, and it is done oftentimes for operational efficiencies.
Mm-hmm. This whole kind of general idea about cost efficiency inside the private equity ownership model, like everything else, it means different things to different people, right? So let's talk about back office functions. billing and collecting, going back to that topic again. I would dare say that many small physician practices that are considering selling to a private equity, for example, probably don't do that. They definitely don't do it at scale, and even subscale probably don't do it very effectively and efficiently. There's probably best practices and experiences that a good healthcare private equity firm can introduce into that organization that's going to improve that and effectively lower the net cost of producing a bill out on the street. And then you get into things like, scheduling effectiveness of clinicians, et cetera. They always bring best practices outside of healthcare, inside of healthcare, and they usually do it through the management team, of course. And that in and of itself, I think, can be a value add, because healthcare has historically tended to be pretty insular in how we manage and operate.
Interesting.
If you bring best practices from outside of the industry applied to the unique mission purpose that exists in healthcare, I think there's an opportunity for value.
Let's talk about another topic that's kind of big in this area, is employee morale, retention, and burnout. How have you all seen this play in private equity? Is it usually one of the reasons that a healthcare provider or a physician's practice wants to sell? They're burned out, I've got to quit working so darn hard? Or is it after they've sold, they're like, now I'm working even harder? What do you all see?
Yeah, interesting. The topic of burnout in healthcare is something I'm probably pretty passionate about. It transcends a private equity conversation, any other capital formation discussions we could have, et cetera. This is something that I think is a significant risk to the viability of the healthcare system overall, the ecosystem we deal with. It's kind of like the epidemic after the pandemic kind of effect here, which the work has just gotten incredibly hard for a clinic. It's always been a very challenging field to be in, regardless of what clinical discipline or specialty. It's always been very, very hard. But it's gotten significantly harder over the last 5-6 years. And there's a lot of different reasons. Increased kind of toxicity in the workplace and exposure to actually workplace violence in the healthcare setting. There was a time when you were talking to your doctor, your nurse, and they were the unquestioned expert on what they're talking about, and now random family members and people with no experience will challenge him, and it's not nearly as an esteemed profession as definitely should be, in my opinion. But there's a lot of things that are happening, and what's happening as consequences, people are choosing either to tap out and reduce their participation as part of the healthcare workforce, or just as bad, never go into it at all. The association of private equity as either an enabler or disabler around burnout is a reach, in my opinion. It's environmental, it's systemic, and it's also something that we all should be thinking about.
What do you think, Marty, about the burnout factor and the retention factor?
I agree with everything that Mike said. I want to offer a perspective, though, on particularly emergency room physicians, and can feel comfortable doing that because I'm not employed by Teamhealth. Teamhealth is owned by private equity. We represent hospitals, providers all over the country, and one of their biggest challenges, sometimes it's annually, but one of their biggest challenges is ensuring that they have resourced all of their hospital-based physician services. That's emergency room, radiology, anesthesiology, those types of things. Emergency room is, in some communities, well over 50% of the admissions from an inpatient standpoint, and it's certainly a big part of the referral program to specialists in that community. It's critical. And the hospitals that try to manage that on their own, they constantly, first of all, their physicians age out, their physicians burn out. Getting the resources to be able to accomplish something like that. And it allows the physicians that are in those situations to be able to tap out. I need a break. I need to take some time off, et cetera, as opposed to if they're the only ones in charge of an ER in a community and they can't go on vacation, that's where burnout.
What is your experience with some of the physician practices and others that you've represented? What is their experience? Do they sell because of burnout, or after they sell, do they experience burnout? What's your experience?
Yeah, they're not, the ones that we've been called in to represent, they're not selling because of burnout. They are selling for succession planning, or the ability to add locations without using their own capital.
Okay, once they sell, then what's their
But
morale?
it depends, but the ones that we've seen that are very disappointed in it, they haven't chosen the right partner. And it's hard to sell professional services. And being a physician is a professional service, just like an accountant, just like a law firm. And what happens is, a lot of times the upfront dollars are literally coming out of future compensation down the road. So we've seen that. And it's great to get that upfront check, but if you're still covering the same shifts, if you're still...
For a lot less pay because you got the upfront.
And listen, you understand the bargain when you go into it. It's not like it's a surprise, but year 3, year 4, year 5, it starts to wane, and it becomes a challenge for some groups. So that's why they really need to look at the long-term financial implications and strategic implications. What are they trying to accomplish with that?
What is the debate here, do you think, on patient care? Is that an issue that you all see in private equity? Does it improve or suffer when private equity buys up a practice or an outpatient facility?
I think there's cases of both of those across many different subsectors of healthcare, where a change of ownership into a different capital structure, private equity or otherwise, has resulted in a change in patient care. So I would be cautious about generalizing that across a ownership model. Having said that, I would probably say this: I don't think there's any divide between the idea of trying to run or create value out of a clinical enterprise, regardless of whatever, ER physicians, whatever, and the purpose around creating value there, and the purpose of good clinical care, because there's no scenario where a sustained level of poor clinical care is going to result in a good return on investment. It's just not going to happen. What's good for the business is always directly traced back, in my mind, what's good for the patient. And if you want to make it right for the patient, you got to make it right for the people giving the care to the patients, the caregivers. So I would make the case that it's in the expressed interest of any owner, private equity or otherwise, to do everything they can to make sure care is as good as it possibly can be. Because if you really want to get a return on your investment thesis, you're going to have to do that. There's no chasm or divide between those two concepts, in my opinion. The surest way to go out of business is an extended period of poor patient care.
Therein lies, I think, the challenge here with the discussion of, is private equity good or bad for healthcare? Because it's not a fair question. It's change. And it's change for,
Wow, that's pretty basic. The world is changing.
Yeah, but we're in a difficult, it's the most complex business environment, in my opinion, to operate in. The rules, the regulations, the frontline battles with insurance companies that are fought every single day just to get one claim paid to the provider that spent time. So anything you can do at scale to make it more efficient, to get the patient treated well, but also, move on to the next one. That's an important aspect of it.
Healthcare, in particular, complex clinical care, repetition is safety. The more you do something at scale, I don't want a guy operating on my heart who's done it twice. And I would love to go someplace like, in Vanderbilt or one of the large heart institutes that have done it thousands of times.
I do ask that before I have surgery.
It's right? So this idea that
I agree with you on
pursuing
that.
volume in itself creates negative consequences around quality or safety, I think is a flawed perspective. Productivity without guardrails around clinician wellness and well-being can have a negative effect on clinical quality and safety. So you got to have to be able to compartmentalize that holistically to really understand what that means.
Well, the one thing that I've come to realize in the course of our conversation is that this is complicated and vastly important because healthcare is important to all of us, and it sounds like it's the area that needs the most change, and maybe private equity is going to be something that's more important going forward. I don't know, do you all agree with that?
Healthcare has to change and evolve to keep up with the rising demand and the needs of our communities and nation as a whole. It's going to have to reinvent itself a bit. Consumers and payers are going to have to change their expectations of what that might mean ultimately, given that it's not, in theory, an open checkbook around that in terms of kind of our nation's ability to finance its healthcare bills moving forward. And so I think that anything, including private equity, not just or compartmentalized, anything that enables the effective management of change and evolution should be on the table for consideration as potentially part of a number of different solution sets available to help address the growing problem you're talking about.
Well, I would agree with that. I would also say if you think through all the other options, okay, 100% government owned, I think that's
socialized medicine.
That is a significant challenge to and change to the way the United States patient population consumes healthcare. Back to Mike's premise at the very beginning of this, which is speed to transaction and things like that. That may be a potential solution for it. But it all gets back to whoever owns the particular healthcare enterprise, whether it's a surgery center, a hospital, a physician group, et cetera. What are their goals? What are they trying to accomplish? And private equity is one option for them to consider.
Well, I'm so glad we've had two leading experts to guide us through this because this is complicated, and I'm grateful to both of you. Thank you, Marty. Thank you, Mike.
Welcome.
Thank you.
The debate on private equity in healthcare is complex, nuanced, critical, and continues. We all need to understand its impact in this pervasive industry that touches nearly all of us. At the Haslam College of Business, we take on the issues that affect bottom lines and people's lives. I'm Monica Langley. See you next time.